Good morning. Thanks for joining us for today's HIS Talk webinar, Successful HIEs Do Exist, Best Practices for Care Coordination. It's brought to you by Medicity. I'm Lori from HIS Talk and I'll be moderating. I have a few housekeeping items to make you aware of before we get started. Attendee phone lines have been muted to prevent background noise. You can use GoToWebinar's questions box in the console to submit questions to our presenters at any time. The presenters will answer your questions during Q&A, which will be at the end. Today's webinar is being recorded, so you'll receive links to the recording as well as a PDF version of the PowerPoint presentation. In today's webinar, we'll hear from Brian Ahier, Director of Standards and Government Affairs for Medicity. Joining Brian will be Dan Paoletti, who is the CEO of Ohio Health Information Partnership. And with that, I'll turn it over to you, Brian.
Thank you. Hi, everyone. As she said, I'm the Director of Standards and Government Affairs at Medicity. Also sit on the Interoperability and HIE work group for the HIT Policy Committee, and been involved in health information exchange and looking at population health management tools for some time. So I'll dive right in here. Just some introductory stuff before we get to Dan, who's the real meat of the presentation today, to show the boots on the ground and real life success of health data exchange in Ohio. We look at HIE really as the cornerstone of value-based care. And when you think about, if you're going to be entering into risk-sharing arrangements like accountable care organizations or shared savings program, the need for data is acute. And so health information exchange is the foundation for population health. And, we've made, even though interoperability really has been getting a bad rap lately, I think we've made some very good strides towards exchange. Certainly in the state of Ohio, they have robust exchange capabilities. And so we're powering today. But then thinking about the future as well, what does the future of HIE look like, where we care for entire populations, where you have both engaged providers and patients, and having patients have access to their health information, and the new tools and services, the standards that are being developed around APIs, such as HL7's FHIR. Today, the traditional HIE focus has really been around the 45% of these data sets that people are exchanging today, and it's very valuable, it's very important, linking up a hospital with physician practices, incorporating public health data, being able to do reporting to public health agencies, results delivery from labs and pathology and radiology. Incredibly important, but we want to add to that the rest of the health data ecosystem. So when you start thinking about other hospitals, and Dan will give some stats on that, Ohio certainly has, I think, is one of the leaders in the nation around connecting up many hospitals, right? And we want to connect up some of these post-acute care settings. We want to have emergency department information. And so the goal ultimately would be to cover 100% of the health data sharing ecosystem out there to really provide the richer data set that's needed to be able to achieve the goals that we have to reach for population health. One thing I did want to mention, I talked just briefly about FHIR, and FHIR is Fast Health Interoperable Resources. And really what FHIR does is, it's the notion of having an API that would provide access to data elements. So today we mostly exchange documents, and that's not going away. But we want to add to that, to the document-centric approach to exchange, also the capability for a data-centric model. The JASON task force made recommendations to the ONC as a result of what was called the JASON report. The JASONs are the super secret spy agency out of MITRE that provides mostly intelligence and defense and sometimes healthcare science briefings to the federal government. And the JASON report on interoperability, as a result of that, the ONC developed a call to action on public APIs. And as a result of that, the Argonaut project was formed, and aligned with that was the SMART group. And SMART was one of the research projects that was funded under the HITECH Act that started to look at medical and reusable technologies for data exchange. And they've really embraced this API model and adopted FHIR as a standard. So between SMART and the Argonaut project and the work that HL7 is doing on FHIR, more to be revealed on that. But I think it's really important to note that in the future of HIE, 3 to 5 years from now, we're not only going to have a richer data set that we're exchanging documents, but also data level access, right? So what that means is rather than having to send and receive a consolidated CDA, which I may still find a lot of value in doing that, obviously, but maybe I just want the problem list and the med list and the allergy list, or I just want certain data elements. And generally speaking, these resources, which are the sort of the atomic units of transaction within FHIR, they generally correspond to the section headers of a consolidated CDA. So I can just get the data that I need. At Medicity, we sort of divide our HIEs into the public side and the private side, right? So the private side being enterprise HIEs, IDNs, and the like, where a health system or even an individual hospital has a need to tie together the disparate systems that they have within their own organization. And that's valuable and important. And at the same time, we have public HIEs, state HIEs, and regional HIEs, where, and oftentimes the government is involved in either governance or funding. So the HITECH Act provided a lot of funds for HIE through its cooperative agreement program to sort of kickstart some of these. Some of them took that money and built a business model around it. Some of them took that money and then failed. You're going to hear today about a state that took that money, built a business model around it, provides value to their stakeholders, and have an ongoing business now that actually I think probably was looking forward to the end of the government funding. The challenge around public HIEs can sometimes be that with government funding comes government strings attached, where the private HIEs are more flexible. They can react to the changes in the marketplace much more quickly. So the Medicity network is massive. We have 9 state-designated entities with 12 regional HIEs around the country, and then 96 enterprise clients with over 250,000 end users. Millions and now billions of transactions have occurred on this network, and this is just our network, the Medicity network. So when people say that, you know, there's no data exchange happening, interoperability is a failure, and all of that, I would take exception with that. I think we're doing a really good job building out both us and the federal government and our partners in the federal government, and even some other vendors have done a pretty good job at building out a national infrastructure for data exchange. In certain areas, as you can see, there's a really robust exchange taking place. You know, you look at Ohio on there, you can't even see the Ohio, the CliniSync HIE, because it's surrounded with so many enterprise clients as well. You know, there's a lot of exchange happening, and again, Ohio is sort of a beacon for the nation, I think, when you look at what's possible and what we can do today, and also planning ahead for what's coming tomorrow. And just one quick example of the real key importance of this, right? It's all about the patient. So we want to be able to provide better care and actually improve outcomes. So in this case, which was demonstrated at the HIE'S conference recently, you know, the patient presented at the ER. They thought probably it was cellulitis, but because they had access to recent data in the HIE, they could see the vascular study from the previous week at a different hospital that showed a clear vascular deficiency. So instead of admitting the patient to the hospital, the patient was appropriately diagnosed and transferred to a vascular surgeon with bypass surgery, which ultimately saved her leg. So we, you know, by having actionable information at the point of care, it can make a real difference in real people's lives. And I think that that's important. Obviously, you know, you save a lot of money, you improve outcomes, and you improve the patient experience by doing this. And this is, you know, what we term the triple aim. It's the goal for everyone, right? We want to be able to achieve the goals of the triple aim, and I think population health management is sort of at the bullseye of this target where when we try to achieve the goals of the triple aim, it's the population health management tools with HIE as a foundation for that really are going to help us to thrive in a transformed healthcare system. So I want to take a look at sort of how we view this, right? When we look into a community, and obviously everybody doesn't implement everything all at once, but really we have workflow over on the right, analysis over on the left, and starting at the bottom, when you think about you want to be able to aggregate data and layering over, these are our solution sets at Medicity that we have for our population health management tools, and Exchange being the first one, which I'm going to talk about in a minute, leading up into Organize, being able to aggregate data, being able to deliver results, being able to place orders, being able to fold in some of these other data sets, being able to engage patients through a portal, up into Workflow where we talk about care coordination using our Connect software suite, and then Engage is the patient engagement piece through, if you're in a risk-sharing arrangement, certainly Manage is very important around care management, and then the really deep and robust capabilities of analytics, and Notify, which is our newest product, which provides clinical alerts, and I think is incredibly valuable. So you need to know what's going on with your patients in real time. Doing retrospective analysis is helpful, but not very helpful when you consider that the patient was already admitted to the hospital with a CHF diagnosis. So they've already been to an expensive emergency department, avoidable ED visits. So having notifications and real-time clinical alerts is critical and key, and I'll leave it at that because I'm really only going to talk about today the 3 solution sets that I think highlight the success that Dan's going to show us in just a minute. The first being with Connect, which is really around our Health ISP for direct secure messaging and our referrals management solutions. And the idea behind this is to be able to enable collaboration and coordination through referral management and messaging. And then this is also critically important when you think about meaningful use requirements for transitions of care or other federal and regulatory activities that are taking place now with the merit incentive payment system, with the repeal of SGR. And that's a whole nother webinar on itself, but certainly Medicity Connect can help not only improve care coordination, but also achieve those regulatory requirements. And it has a real impact on reducing waste and the PCP follow-up post-hospital visit. It certainly improves when you have access to this information and when you can communicate in this way. Exchange is a more robust platform, allowing for orders, for results delivery, and for the exchange of clinical summaries. So having notes, being able to be exchanged, having clinical notes at the point of care, a study, and this is 10 years ago. I'm sure now, as technology has improved, if we could get some more studies that would show the real value around this. Having the right information at the right time at the point of care, actionable information that can actually impact the care of the patient, that can improve outcomes and ultimately lower costs. And then finally, Medicity Organize, which incorporates our community health record. And this is where you now begin to aggregate data across the community, where you have a longitudinal view of the patient record. And then we can start to layer in some of these risk prediction tools, Care Engine, and some of the analytics capabilities that we have within Organize. And so I think that, you know, this is probably now where we're moving beyond it, just HIE, which is the foundation, but being able to layer in these other capabilities when you start thinking about what you're going to need in order to not only survive but thrive in the future of healthcare. As more and more of you that are listening today are likely starting to be in risk-sharing arrangements, and you're starting to go at risk as a provider, and you're sort of joining hands with other healthcare organizations that you've been previously in friendly competition for market share with, that now you're finding yourselves partners in the community of improving health. And, you know, I always say shared risk requires shared data. Right? So whether you're joining with other healthcare organizations, with payers, with employers, and you're thinking about how we're going to be able to really not only improve outcomes, and I always put the patient at the center of everything, and I think that's the key, right? We want to have a healthier population, but ultimately a healthier population also reduce costs, and under these new payment and care delivery models, then you're able to really leverage that for a better financial picture. So with that, I'm going to hand it over to Dan Paoletti, and he's going to walk us through the solutions that they've implemented in Ohio. Thanks, Dan.
Thank you, Brian, and good morning, everybody. My name is Dan Paoletti, and I am the CEO of the Ohio Health Information Partnership. The partnership is the organization which runs the Health Information Exchange, which will be referred to as CliniSync throughout the presentation. The goals for today are really for you to walk away with something that will be helpful for you. One of the things that I'll point out right up front is that we recognize every state is different, every region is different, and every community is different. And again, hopefully what's going on in Ohio, because we are a microcosm of the country, we have a very large rural population with over 30 critical access hospitals. We have 3 metropolitan areas with well over 1 million residents in each city, and we have several other large metropolitan areas scattered throughout the state that we know you have to be a little bit diverse in what you're offering, and one solution isn't going to solve the problems for everybody. So again, throughout the presentation, hopefully you'll be able to pick up something that is beneficial for you and you can take back and find useful. I'd like to start out really by pointing out that information exchange really isn't about technology anymore. Yes, we do have some ways to improve and to go with interoperability, but it ultimately comes down to community and the trust that community has to facilitate information exchange. And the more you can get community buy-in, the more you can bring it down to solving solutions in each individual community, the more robust and the more adoption that you will find when it comes to exchanging information on behalf of caring for the patients. So health information exchange, we break it down to its most basic element. It really is about the data. And the data is, as we view it, a very core piece of moving towards healthcare reform. And there's so many different pieces and parts of healthcare reform and caring for the patient that the data is really applicable for, that we could spend hours talking about this, but we're really going to focus today on the care coordination piece of that. We'll touch a little bit on the patient privacy, the data governance, and the interoperability, but most of the presentation is going to be on the coordination. And again, health information exchange is just one critical piece of care coordination. Again, it really comes back to the community and the community facilitating health information exchange on behalf of the patients that are being served. So as we break it down a little bit further, again, this is really about a medical neighborhood. And CliniSync, again, the health information exchange that we're discussing today, is the goal here is to connect the different providers and the different people caring for those patients together, and allowing them to exchange information and have the information they need at their fingertips to care for those patients. We are a nonprofit. We'll talk a little bit about how we were founded here shortly. But again, one of the most important things you can walk away from this is it really is a grassroots effort. Getting people in the community to support what you're doing, to support the idea of information exchange, is really critical to widespread adoption. We really do want to break it down even further, because ultimately this is about the patient. We probably wouldn't need to be exchanging information if we weren't caring for patients. And around this patient, again, the larger conversation around healthcare reform is ultimately important. But going back to a slide earlier, there's a lot more providers and people that are involved in the patient's lives than just the hospital and the labs. This is really about reaching out into the community and making sure that all those people that are surrounding that patient have access to the information and can contribute information to care for that patient. And that's what we'll talk a lot about today. So, benefits of HIE, and again, I think there's a lot of benefits that are well documented. There's a lot of benefits that are still in theory, but ultimately, some of the things know is that get information to the provider when they need it. It can help provide more efficient care, more effective care. It can help with those transitions of care, so the patient has a smoother transition, and making sure that as that patient is moving from setting to setting, the information is following them. I think the concept of having that information in the emergency room is probably well documented. Brian even touched a little bit on it earlier. And ultimately, what we're talking about here is, again, making sure that the information can follow the patient, and making sure that the providers and the other entities that are assisting with the care of that patient can access it and can contribute to that patient's information. So, Ohio, let's talk a little bit about that. As I mentioned, we are a nonprofit. We were established in 2009. We served two main purposes in the beginning. We were a statewide regional extension center for 77 out of the 88 counties. We were also the state designated entity. We have one other health information exchange that operates in the state, and that's HealthBridge in Cincinnati, and we're working very hard with them to facilitate movement between the two organizations. We have 141 hospitals, most of them in Ohio, but a couple of them are not, that are contracted with us. The vast majority of those are implemented and live. You can see those in green. The yellow ones, we hope the balance of those, which is about 39, will be live towards the end of the summer, and then a few will sprinkle on into the fall. And again, an important thing to take away from this slide is about 87% of Ohioans are seeking care from providers that are participating in the health information exchange. And so when you have that kind of penetration, the idea of what you can do with that information and the impact that can have on the care of those patients and the efficiencies it can bring and the impact it can have on healthcare transformation. We're just now scratching the surface of that, but we're really excited about what this holds for the future. In addition to the hospitals, we are working with about 4,000 independent affiliated physicians, which represents almost 1,000 practices. We have made a very diligent effort to reach out to the long-term care, post-acute care facilities in the state. That number grows every week. We're also focusing right now on home health, behavioral health, and pharmacies, as those are, we think, other main entities that we need to get connected to very quickly. And the provider directory for direct addresses has grown exponentially. We are up over 13,000 direct addresses now across the state, and you'll see how that's impacted some of the meaningful use requirements and some of the transitions of care that are now flowing across the state. So let's talk a little bit more about how we got started. As I mentioned, we were the Regional Extension Center. That was the first piece of work that we were doing. We were the single largest regional extension center in the country. We were working with over 6,000 primary care physicians with partnerships out in the community using existing resources, consultants, hospitals, to help work with these primary care physicians. As of last February, all 6,000 plus a couple hundred had met meaningful use. So that work on the Regional Extension Center was completed, but it was really critical to understand that without that adoption, we could not be successful with robust health information exchange. So the fundamental concept of the medical record is so key to the health information exchange. I can't underestimate the importance of that. Ohio itself has had great success with meaningful use. We are well over 18,000 providers that have achieved meaningful use with a substantial amount of money coming into the state to help reimburse the providers for their adoption of electronic medical records. And so that has really, again, helped with the widespread adoption. From there, as we were working through the Regional Extension Center concept, the Health Information Exchange Network concept was put into place. Again, the state back in 2009 designated us as a state-designated entity. We do sit outside of state government, which, again, going back to one of Brian's comments, it does allow us a little bit more flexibility to be able to move more quickly, although we work very diligently to help make sure the state's successful in all of their initiatives, and we'll talk about some of the initiatives and success that Ohio's had from a state perspective on some of their healthcare transformation work. But again, using that high-tech funding to really look at it from a capital investment perspective, how do we set up an infrastructure that can be flexible, bring return on investment to those stakeholders that are engaged, continuously allow us to add new services, change services, potentially drop services, and meet each community's need, knowing that each community is going to be a little bit different. As a result of that, the Medicity platform was chosen. We've been working with them for a number of years, and they've been a very good partner for us. So where we started in the very beginning, we knew we had to get the hospital base. We looked around the country to see what had been successful, what had not been successful, where health information exchanges really did need to improve. And one of the things that really was apparent is that you had to have a critical mass of hospitals supporting the effort. And we determined early on that 100 hospitals was that critical mass, and we knew if we couldn't get there, that we may be in jeopardy of not being around very long. Fortunately, we had some great champions, some large healthcare systems, small hospital, community hospitals, critical access hospitals, rural-based facilities that worked with us to develop a model that would not only bring them some benefit, but could grow as their needs changed. And so in the beginning, it was really around results and moving information from the hospitals out into the community. That is growing even as we speak today, and we still have some additional work to do on that. But ultimately, we want to make sure that that information can be dropped electronically into the providers' offices in the community and reach out to the long-term care, the home health, and give them access to that critical information that they need. From there, again, primarily because of the work that was driven through ONC, we also felt that health information service provider and direct was important, and again, large importance to help maximize the standards that were being created through ONC, and so we went through the direct trust certification. As I mentioned, our provider directory of those direct email addresses has grown substantially over the last year, and we worked very hard to help providers in the community meet their meaningful use primarily through the transitions of care, and we have large numbers of transition to care documents being moved across the state, both through us, partially through us, but also without us. But again, what's important there is the community got together and figured out a way to get all of the HIEs to work together and make this work. We also were told that Healtheway Certification was going to be critical for many of our stakeholders, not only to exchange across state boundaries, but with the VA, the Social Security Administration. So we worked through that certification with eHealth Exchange last spring and have been a member since last summer. We are working with Healtheway to explore some additional benefits that we can bring to stakeholders, both using their existing EMR technology and outside of that. Again, we think both Direct Trust and Healtheway will be an important piece of what we're doing for quite a while to come. So from there, we launched the community health record and the referral management tool. These are fairly new for us, but we are seeing widespread adoption of this. And the referral management tool is a closed-loop referral system that really allows physicians, hospitals, long-term care, social services, and others that interact with the patient to surround the patient, understand what's going on with them, get things scheduled, move clinical information around, and be able to communicate inside of the tool to make sure that that patient is properly cared for. We have several pilot projects around the referral management system, and we have several large projects that are getting ready to kick off. But we see this as a pretty critical tool set that is going to be used in a large way across the state. We also just launched the community health record. So all the information that was flowing through the system for the results delivery for the referral tool also feeds the community health record. We are an opt-in model. Early on, the stakeholders felt it was important that the patients did have a choice and did authorize bringing information from several data entities together. That was, again, we spent a long time trying to understand, how to roll that out, the best way to roll that out. But what I will tell you is this is ever changing. While we are still an opt-in model, our opt-in process is even as we speak undergoing some changes to better meet the needs of the community, the patients that are cared for, and to make sure that we are flexible enough to really fit inside the workflow of all of the stakeholders. That community health record, again, is important. We are already seeing some great impacts with making sure that that information is available out into the community as the patients are moving from provider to provider, and that will be a main focus for us throughout the rest of the year, rolling that out to the balance of the state. In short, these are all the services that we are currently working on. We have some additional things that we're looking to add on to the network, and some entrepreneurs that have come to us with some interesting ideas that we're exploring. But we've talked about the results delivery, the community health record, and the referral management. We are also now rolling out orders, the ability to place orders through the system so they can match up to the results delivery. That has been very well received, and we have a number of those projects ongoing. Brian mentioned notifications. Notifications seem to be very critical for a number of different use cases, everything from behavioral health to dialysis centers to patient-centered medical home to case management for ACO'S and the payers, that we see all different types of use cases with this. We've also rolled out into health plan services. We have a number of agreements in place and a number that are being worked on to more efficiently move information from the providers in the hospitals to the health plans. And again, those are also what I would say, everybody's a little bit different here and everybody has a little bit different need. So trying to make sure that the technology can meet all those different use cases is what we spend a lot of time working on and working with the stakeholders in Medicity, trying to meet all those needs. We're also taking our provider directory and making that a web-based application, which will be launched at the end of the summer. So it will have more easy access to that, and people can update their records and as that grows. Public health is also key. Doing a lot of public health coordination, moving things that are required in Ohio to the Department of Health on behalf of our stakeholders. And our regional extension center work has moved from that initial meaningful use work to more practice consulting. So we've kind of transitioned that, and we're looking at doing a lot of different things with that, especially with the smaller providers and across the state. And as I mentioned, what's not up here is our ongoing work with HealthBridge and making sure that we can facilitate information exchange across not only Ohio, but also with some of our surrounding states, such as Indiana and Michigan and West Virginia and Pennsylvania and Kentucky. So let's talk about interoperability, because to make information exchange happen, interoperability is really crucial, and there's a lot going on across the country around that. We have worked hard with most of the large vendors across the country to do some standard interfaces. And what we found is that if we can get the clients, our mutual clients, to really champion the cause of making that information exchange easier and more affordable. And we work through those clients with the vendors that we've had pretty good success working with them, and the vendors have really been good to work with. I think the key here is making those mutual clients the champions to facilitate that, and really developing the use cases so it's really a clear statement of work. We still have a ways to go with that, and I'm the first to admit that, but what I would say, it is possible, it is being done, and it's exciting to see what the future holds with this. And ultimately what we want to do is keep the care provider in their EMR experience, and that's ultimately where we need to head. And again, with these underserved areas, we also have to keep into account that we are trying to help communities that don't have a lot of resources. So we will always have to have the web portals and those other tool sets that can help those communities be successful as well. So let's kind of circle back to payment reform just for a little bit, because ultimately care coordination is being pushed and dictated by the healthcare reform efforts coming both at the state level and federal level. In Ohio, the current governor, Governor Kasich, created the Office of Healthcare Transformation. It's an office that has done a lot of work trying to move transformation of healthcare in a very fast way across the state. We are a recipient of one of the SIM awards and the CPCI awards in Southwest Ohio. So we have a lot of efforts, and ultimately the goal with information is to help those efforts be successful, and to help healthcare reform be successful, and to help care coordination be successful. And ultimately, you know, looking at the different models in Ohio that are being rolled out with the SIM work, it's really around episodic care, bundled payments, and patient-centered medical home, and expanding the CPCI work that's being done in Southwest Ohio. And again, it comes back to facilitating the movement of that data across the continuum for care coordination, for population health, and for proving that these models are being successful. So health information exchange is one part of that, but again, it comes back to the data and making sure that the data can get where it needs to go to help support all of these efforts. So with payment reform, again, in the one box here in the right-hand corner, we talk about health information exchange and coordinated care and CliniSync, but ultimately, probably a better name for that box would be data. Again, to help all of this be successful, the data has to get where it needs to go in a way that has strong governance, can protect patient privacy, but also facilitate the transformation that's going and the transformation that is yet to come. Again, the data is the key, and that's really where we're focusing a lot of our efforts. So just in review, let's talk about some of the suggestions. And again, as I mentioned in the beginning, I know all these aren't going to be applicable for all of you on the phone, but I do think there's some real important things that have helped us be successful. That whole grassroots approach, when you look at large information exchange efforts, you know, across the state or across the region, you really have to have the community to buy in, and you have to have some champions that are willing to make the cause their own and help get others in the community to buy in, so it's not just you trying to do it. And fortunately, we've had that in the state, and there's a lot of entities that will never get the credit they deserve for helping information exchange grow like it has, but that's really been one key. Also, as I mentioned in the beginning, every community is a little bit different, and you can't go in with this is the way it has to be done, and if you can't do it this way, we're not going to be able to help you. The communities really have different needs, and trying to understand those needs and help them facilitate that work and kind of putting them in a decision-making capacity has really been key. And again, we have a long way to go here. yet, because there's a lot of communities we're still reaching out to, but again, they can help drive all of this. Meaningful use, stage 2 and stage 3 are going to continue to be important, so they still have to be a focus. Making sure that the work that we're doing is helping the provider community meet those ongoing meaningful use requirements is also very critical. I mentioned the provider directory. Making sure that access of that provider directory is easy and efficient, we also think is going to be very important. And a phased-in approach. Again, as I mentioned, there was a critical mass that we needed to start with, and the larger the mass, the more affordable you can make the services. So again, the larger you can grow the organization and facilitate the exchange and bring additional communities on, the more you can lower the cost of the individual participants. And again, not trying to do everything at once has been pretty important for us, but phasing that in also allows you to be a little more flexible as you start to understand what healthcare reform needs are and what data needs are. One of the things that I think is pretty apparent, nobody really knows what all information is really going to be crucial to be successful when it comes to healthcare reform, but people are starting to get a pretty good idea, and our goal is to make sure that we are the data source that they need to go to help them be successful. And again, all this is about a return on investment. Even though this is about care of the patient, it also has to bring a return on the investment that's being made, and always looking at that and figuring out where we can improve on that. And ultimately, again, just making sure we're providing the tools to coordinate that care in the individual communities. So there's a lot here. I'd be happy to help anybody after the presentation if they have additional questions. We'll put some contact information on the last slide. So just a couple of things, and again, people ask me all the time, when are we going to know that we're successful? And ultimately what I would say is, I know that we will have been truly successful when no one wants to talk to me again. What they want to do is talk to the community and the people that are using the tool set, because that means that we're really able to start to show benefit and the real hard-term effects of information exchange across the community. But we're starting to begin to see that. And again, I think, you know, moving information electronically so it lands in a discrete way is one very critical piece of what we're doing. As I mentioned, the direct messaging and maximizing the use of the CCD and CCDA. Again, while I know there's some improvements that need to be made in those formats, it's still a very good standard that's available, and certified EMRs can be able to produce that, and we can move that information across the community to help coordinate care. And then also making sure the information can follow the patient and can be accessed as it's needed is what we're really at this year, and what we're going to be focusing on not only this year but throughout the next couple of years. So again, hopefully this time next year we'll be able to bring some of the community providers to really talk about how they're using health information exchange and how it's affecting the care of the patient and affecting their practices. Again, I'd like to end and bring it back to the patient, because as I mentioned in the beginning, this is really about each individual patient. And again, we always have to remember that the information that's being moved is information for that patient, and it's got to be treated as such. And the data governance around all of this, everybody has to have a very high trust level of what's going on. The communities have to buy in, and ultimately we have to be protecting all this on behalf of the patient. So again, we come back to this slide where we put data right smack in the middle. Ultimately, what we need to do is make sure we're constantly building that data set in a way, in a proper way, reaching out to the other entities, long-term care, pharmacy, social services, and all these other entities that affect, you know, a patient's care and the ability for the patient to progress throughout the system, and ultimately how that will affect all these other pieces of healthcare reform. So with that, my contact information is up on the slide, and I will at this point hand it back to Lori to open up for questions.
Okay, thanks, Dan. Now we'd like to open it up to the audience for questions. As a reminder, you can use the questions section on the GoToWebinar panel to submit your questions to Brian and/or Dan. The first question, have any of the participant IDNs also joined Healtheway, and has this had any impact on the HIE?
Yeah, this is Brian. Well, let me start, and you can talk. I'll take a more macro view, right, of how that looks nationally, and then Dan, you could drill down into the experience you've had in Ohio and the surrounding states. But you know, the answer is yes. There are often times where you see an IDN that joins the eHealth exchange, participates in the eHealth exchange, you know, and then also the state HIE is connecting to the eHealth exchange or thinking about connecting to the eHealth exchange. And, you know, I guess there's an impact there, although, you know, a lot of people are experiencing the fear and loathing of HIE value proposition and ROI for the broad-based exchange efforts and capabilities that we've built out. And I think that those fears, while certainly we need to take a hard look at the governance model nationally, and we are doing that. And you know, if you look at the ONC report to Congress last month on information blocking, you know, certainly it's an area that not only the HHS and CMS and ONC are looking at, but the Congress itself is looking in terms of how we can have avoid vendor lock-in and have the most seamless flow of information. But, you know, to me, the important point, and Dan highlighted this when he talked about Healtheway or exchange, the eHealth exchange and direct trust. I think of exchange and direct as, you know, and then ultimately FHIR going forward, all existing, coexisting side by side, complementary technologies to each other. And I view the same way when people are connecting different data sharing networks together. So whether it's a regional HIO that's connecting through direct trust and then also connecting to eHealth exchange and the state HIE and different IDNs are doing, we're building out a sort of a network of networks. And so that's how I look at it from a high level, at a macro level. And Dan, it'd be interesting to know what your experience has been in Ohio specifically and in the surrounding states there.
Yeah, no, I would say the more the better as far as adoption of the eHealth exchange. So we have had several health systems go through that independently. We've done it. HealthBridge has done it. We are actually looking at working with Healtheway to help other health systems go through the process using us as a facilitator, but independent of the Medicity technology stack. We think the more people on that, the better off the state will be. We don't look at it as a threat. We look at it kind of half, the glass is half full kind of concept. And ultimately, I guess one of the things I'd stress, health information exchange as the noun is not the most important thing we do. It is really facilitating the information exchange. The verb is really what we do. So we can't be afraid of doing things that might potentially put us out of business. We have to be flexible enough to figure out how to make everybody successful, regardless of whether it's a threat to what we do or not.
Yeah, and to your earlier point too, Dan, around you know, that how do you gauge success? It's when no one needs to talk to you anymore, and we sort of look at that the same way. The more invisible we are, the better, right? The clinicians out there that are connecting, they don't want to hear about Healtheway and, you know, direct and all the different. When you look at the analogy of the cell phone networks, they care about dial tone. They want to be able to connect and have it integrated into their workflow. with as little interruption as possible. And so I completely agree with all the points you made.
Okay. The next one is a direct email question. What do you mean by integrated and standalone? Do you use individual organization direct addresses or a single CliniSync direct address?
Yeah, so that's a very good question. So we do integrated HIS solutions into the EMRs. So we have had several hospitals and other entities take our health information service provider network and integrate it directly into their EHR. So that's an integrated solution. But in many cases, such as long-term care, that may not be feasible. So we set up a standalone web-based solution where they can also engage and direct, but they don't have to do an integrated solution. So we will prop up either for the stakeholder depending on the need, but also, you know, when stage 2 was just starting and most of the hospitals were pursuing that, there were a lot of people in the community that they needed to be able to send these transitions of care to. So while we may have done an integrated solution for them or they had their own integrated solution, we would set up endpoints out in the community for them to make sure that they could get those out there.
Okay, Todd would like to know what your approach is when reaching out to communities and long-term care centers to express the importance of participating in the HIE.
So with the long-term care centers, once we started to have, you know, one-on-one conversations with them, they were really an eager participant. They had several business needs that they are trying to solve and still trying to solve. Results is just one part, you know, moving those results to them in a more efficient way and ultimately trying to get those results into their EMR electronically. That's a big part of what they're trying to solve. But care coordination and case management and facilitating the transition of care from the hospitals and from their facilities and back, there's a big need out there. And if you can help facilitate that in a way that's cost efficient for them, they are really eager participants. So it really comes down to getting the information to them, helping them move the information around, and ultimately care coordination, which right now is primarily between what we're doing between them and the hospitals. But the whole concept of medical neighborhood is really growing and kind of getting legs of its own.
Steve is interested in what your top challenges were in connecting across so many providers.
Integration. So integration itself is probably the single biggest challenge we have. And again, while it can be done, it is time consuming. So getting all the hospitals, developing the integrated solution into them to facilitate the movement of that data, working with all of the ambulatory and long-term care vendors to do that integration. While, again, as I mentioned, they, for the most part, have been really good to work with, it does take time and effort and coordination, and you have to get the clients, the mutual clients involved, which also takes some time. But that itself is probably one of our biggest challenges, but it's getting much more streamlined now that everybody kind of knows what we're doing and understands the importance, and everybody is more or less behind it, and we've been able to progress and have a better understanding of how to work with everybody. That is becoming more efficient. And the other thing I would say in the very beginning is the trust. So when you build a system that has grown as quickly as we have, and I think currently we have 6 million unique patients in the community health record now, building it in a way that everybody trusts how the information is going to be accessed and used and audited and protected, it was really very time consuming in the beginning, and is ongoing. As I mentioned, we're constantly reevaluating that, looking at our consent model, making sure that people understand you know, how the system is audited and can be used is also fairly time consuming.
You know, I think, Dan, that's probably one of the keys to success, that not only that we've seen in Ohio, but other states that have had really these remarkable stories of connectivity, is, you know, being the neutral convener and being the trusted agent that, you know, allows these organizations to sort of come together like, you know, two porcupines that want to give each other a kiss. And it's a dangerous place sometimes to be in between those two porcupines. But where I see the most success, and certainly some of the things that you guys have been able to accomplish, is really being that trusted third-party neutral convener that collaborates with all the stakeholders.
Yeah, and Brian, I will say too, I can't stress enough the emphasis of having those champions, those community champions behind you. And as I mentioned, you know, most of those entities will never get the credit they deserve, but they are really the ones that are making this happen. We are more or less facilitating, but it's those entities that are out there driving the communities forward and making sure that everybody knows what's going on and understands the importance. And to be candid, have bear the brunt of us growing and our growing pains and trying to make sure that we can do all of this. So we've had these folks stick with us over the last 4 years, and they've been great stakeholders.
How do you ensure records for the same patient from various hospitals or clinics are connected to the correct person 100% of the time? Is there a team that checks for duplicates, or are you using a software or something else?
Yeah, wow, that's we could spend an hour just on that. But to kind of make a long story short, ultimately what we decided to use the MPI that was built into the Medicity system. We looked at some other options, but I go back to something I said earlier. We looked very hard to see what had been successful and what had not been successful across the country, and patient matching seemed to be a struggle everywhere. So early on, we worked with the stakeholders to try to figure out how can we minimize the impact of patient matching, and what we came up with, and again, these early stakeholders, the ones who really kind of worked out the workflow, is that every single transaction that comes to us, whether it's a CCD, an ADT, a lab, a radiology, whatever it is, has to have enough demographics in the transaction to stand on its own. And if it doesn't have enough demographics, it fails. And we customize what those demographics are going to be with each individual entity that we're working with. So everybody knows what the expectations are going on in front. And what we found is by increasing the accuracy of the information coming to us, took our patient matching from, you know, virtually, which could have been a nightmare, to something that is very strong and robust. And it's just because we're getting good data coming in. We do have people that are looking at that. Our stakeholders look at that and also work with us to send updates through the system and correct records. So yeah, it's not perfect, but we've really been able to kind of minimize the impact of that and develop some processes. As we grow, we'll probably have to add some staff to keep up with the volume, but right now we have a pretty good process in place.
Okay, Dan, have any of the FQHCs in Ohio interfaced with CliniSync, and what EHR vendors have you been able to interface with?
So yes, we're working with many of the FQHCs on results on interfacing into their system. The next phase of that is being able to allow them to contribute data back up to the community health record and to us. So we've had some great champions on that, and the FQHCs have been very active both on our board and leadership councils and everything that we do. What we can do is, Lori, we can send a slide of the EMRs that we're working with. That might be easier. It's up to about 30, but it's all the usual suspects for the most part. But we can send you a list, and that might be easier for people to take in than me just kind of listing them off here.
Okay.
Yeah, you know, you guys have certainly done a great deal of integration work in Ohio, but nationally, Medicity is connected to well over 250 different EHR platforms throughout all of our clients and customers. So, you know, I'll be happy to add to Dan's list as well to give us a national perspective.
Yeah, one thing that I will say that we learned over time, and it took us probably a little bit longer to learn this lesson than I would have liked, but getting to the right people, having the large practice or the health system facilitate this with the EMR company, and trying to work with them to say, look, we don't want to do this in a one-off kind of situation, because we have 100 of your clients in Ohio, or we have 500 clients in Ohio. How can we do this from looking at things in a kind of in mass perspective as opposed to one-offs? And in the beginning, that was hard because, you know, like most people thought we'd probably just go away once the grant funding was ended. But as we grew and people started to understand the number of people that were being connected, we're having much better conversations with those. And again, they really do have some creative solutions, most of these companies. So it's really trying to figure out how to do this on large scale instead of one at a time.
Okay, we're out of time, so for those of you who have asked questions that have not been answered, we'll send responses to you in email directly so we can wrap up on time. Thank you for joining us today, and thank you, Brian and Dan, for a really interesting and informative presentation. Attendees, watch your email for links to the recording of today's webinar, as well as the PDF version of the PowerPoint presentation, and also I'll include a list of the EHRs that I get from Brian and Dan. So we look forward to seeing you at our next HIS Talk webinar, and I hope you enjoy the rest of your day.